Good morning, all. I am Dr. Amit Naghate, diabetologist and a diabetic foot care expert, practicing in Aurangabad, city of Aurangabad, Maharashtra, India. Today, I am discussing the topic of offloading. As we all know, diabetes mellitus affects our legs in two ways, majorly by formation of end glycation end products, which leads to neuropathy, vasculopathy. Neuropathy, we have got motor, sensory, and autonomic neuropathy, which leads to lots of protective sensations, deformity formation, high pressure points, callosity formation. The autonomic neuropathy leads to dryness of skin, which leads to cracks, and sometimes within the cracks there might be the bacteria goes in and the infection formation happens. This neuropathy can turns on and affect us our foot in form of charcot foot orthopathy, whereas vascular acts in two ways, or microvascular angiopathy and a macrovascular angiopathy, where we have got structural abnormalities with AV shunting in macrovascular angiopathy. And the macrovascular angiopathy, we have vascular occlusion leading to ischemia and gangrene of the foot. Risk factor for ulcer formation in general and systemic contribution because of uncontrolled diabetes, duration of diabetes, peripheral vascular disease, blurred vision, chronic renal disease, old ages. Whereas local factors affects majorly for because of peripheral neuropathy, structural deformities, trauma, callus, the previous history of ulceration, prolonged elevated pressures, and limited joint mobility. How does foot injury occur in a diabetic patient? It's majorly because of pressure. Pressure is equal to force divided by the area. The body exerts two type of force: a normal perpendicular force, body surface on the force, and a shear force which is tangent to the body surface. A smaller contact area is equal to higher pressure point. Just like our metatarsal heads, which are rounded in shape, once we that rounded body or a rounded object comes in contact with a flatter surface area, there is higher pressure point in between the two contact areas. Hence, there is the ulcer formation or a skin breakdown can happen. Skin breakdown usually happens between 500 to 700 kilopascals. Once we reduce the pressure below the 500 kilopascal, then the healing starts in. Deformities can cause more elevation of pressure, and callosity in turn itself raise pressure by 30 times as per the nomenclature. Here there is a callosity increases the pressure, which I told you, by 30%. The first figure on your right hand side, there is a callosity over here, just a small nick, and I'm just removing it. Then there is an ulcer formation beneath it, that is a subscalar ulcer formation. The skin breakdowns of plantar pressure exerts 600 kilopascals, because of which anoxia and ischemia occurs. The instant recovery does occur in a non-diabetic patient. Delayed recovery occurs in diabetic patient, which leads to formation of inflammation, warmth, and erythema, which leads to blister formation, and then that tends down to ulcer formation. There is a vascular phenomena where while pressure generation is 600 kilopascal, which I've already shared while walking, if we say that systolic blood pressure, once we exert 120 mm of mercury to obliterate a brachial artery, that is just 15 kilopascals. So while walking, we are having 600 kilopascals. Capillary obliterates at 6 kilopascals. So 100 times or 1000 times the pressure increases, because of which while walking, because of which there is delayed ischemic recovery from ischemic changes, and this leads to tissue loss or tissue damage, low oxygen concentration, and more injuries would happen to the individual. So this is what I was telling about. If we say this is a rounded first metatarsal head, then there is a claw deformity which leads to pressure on the tip, and because of neuropathy, there is a high pressure area. Then this tends to, there are callosities over here, which tends to break down and because of which ulcer formation would occur beneath it. 80% of diabetic foot ulcers are within out. Diabetic foot ulcer is a mechanical problem, and no amount of antibiotic or dressing will heal the wound unless and until we reduce the pressure. The program, which has been we are practicing since long, has given us a very important assessment of risk, high risk foods and ulcer formation. We can see here we have got red patches, red lines, blue lines, green lines. So this is what the graphical representation comes in. And what we do is we usually analyze it that there is a high pressure point over here, then the second metatarsal, and then the second toe and the first metatarsal. So here are the big pressure points elevated. Once we try and redistribute it, this pressure, then there is prevention of ulcer formation in this patients. If we see a podogram, normal foot comes down from heel, second metatarsal head, straight above. Whereas in flat foot, if we can see, the line of axis has changed down. There is a midfoot which is touching down, or pressure occurring at the midfoot. There is a pressure which is occurring at second, third, and fourth metatarsal heads in a flat foot. Whereas high arch foot, there is a highest concentration, or the pressure area which is exerted mainly on first metatarsal head and the first toe or the great toe. The prevention of excess pressure on a point that tends to ulcerate is usually referred to as offloading. It is to remove the factors that causing persistent local ischemia, which leads to ulcer formation and its persistence. Reducing the number of loading cycle, that is a walking cycle, of we reduce walking, then the pressure is not going to be there, so offloading would happen. Or redistributing the pressure by use of offloading, that is by a footwear, offloading footwears, or by surgical offloading. Methods of offloading are bed rest, crutches or walkers, total contact cast, modified footwears, rocker outsoles, outsole wedges, flares, insole stress relieving pads or wings, metatarsal bars or pads, and recently we have started using or doing surgical procedures which helps to offload the foot internally. So in foot orthosis, mainly we have got external and internal orthostic changes. Internally, we do arch support, heel pads, heel cuffs, metatarsal bar, metatarsal pads, and toe separators. These are some images where you can see metatarsal bar is there. There is arch bar, front offloader. There are toe separators here. There is a ring to accommodate the ulcer there. So these are various type of insoles we use to offload the foot. There are the external offloaders where we have got front offloader, we have got hind foot offloader, there is a rocker, and there are some another footwears where this is a footwear where we can accommodate the foot along with the dressing, and these are the pellets which are being removed so that to offload the foot as it is. And once we do a podogram, then we can have a insole, a modified insole, so that we can reduce the pressures and offloading can be afforded. So these are different MCR pads or soles we can directly stick to the inner surface of the footwear, and the foot can be offloaded. So if we see that the normal pressure distribution between, this is schematical normal distribution between flat insole and a molded insole. So in flat insoles, there are peak point pressure points at metatarsal heads as well as the plantar as well. Once we have a molded or a customized insole, then the pressure is evenly redistributed. So this helps us to prevent ulcer formation and pressure molding. So this is what it is. While walking a barefoot, there is a first metatarsal head which is being touching the ground promptly, and pressure is adopted there. If we after giving a rigid rocker insole, the plantar pressure at the forefoot is during the push-up is being reduced by 30%. So these are another footwears or insoles we can directly modify and stick to the inner soles, and the foot can get offloaded. Uh, at high risk foot, just like here, where there are various deformities along with scarring, significant scarring, and this, we go for a molded insoles, and the molded insole goes into the shoe, and the foot is offloaded. There are other offloading devices where fixed ankle braces are being used. In where the foot is unstable or unstable foot, and severe neuropathy with deformities is there. There is another patellar brace where is indicated in less than one third of the plantar surface is available for weight bearing. For example, a shorter or a 4 foot amputated foot is there, and we need to mobilize them. Then patella tendon breast orthosis is can be used. So this is one first. This is a case where 60-year female, known diabetic, came to me for with this con. This is for severe neuropathy. ABI was normal. We just simply debulking. There is a first metatarsal head which is being touching the ground promptly, and pressure is adopted there. If we after giving a rigid rocker insole, the plantar pressure at the forefoot is during the push-up is being reduced by 30%. So these are another footwears or insoles we can directly modify and stick to the inner soles, and the foot can get offloaded. Uh, at high risk foot, just like here, where there are various deformities along with scarring, significant scarring, and this, we go for a molded insoles, and the molded insole goes into the shoe, and the foot is offloaded. There are other offloading devices where fixed ankle braces are being used. In where the foot is unstable or unstable foot, and severe neuropathy with deformities is there. There is another patellar brace where is indicated in less than one third of the plantar surface is available for weight bearing. For example, a shorter or a 4 foot amputated foot is there, and we need to mobilize them. Then patella tendon breast orthosis is can be used. So this is one first. This is a case where 60-year female, known diabetic, came to me for with this con. This is for severe neuropathy. ABI was normal. We just simply debulking of the OPD, debulking of the skin, or removing the upper layer of the tougher skin was done. This is what I mean to say. And after a month with several routine visits, this thing got reduced, and ulcer was been reduced. We did footwear modification with metatarsal bar with a scooping in, so to accommodate the callosity or the deformity. There's another where there is also over here. He underwent shown to plastic surgeon, general surgeon, underwent skin grafting 3 times, had done a punch biopsy. There was nothing found in biopsy, and this. Again, the debulking of the thing was done, offloading was offered. This where the on 42nd day, sugars were where the ulcer got healed completely. This is just the simple offloading method or technique which I have shared you previously. This is what the practical demonstration with my patient I have shown to you. Now, sir, coming down to surgical offloading techniques, where if we have a IP joint ulcer, then what we do is there is a hilus rigidus, there is a toughness of the first metatarsal head due to plantar fascia thickening and intrinsic muscle tightness. So what we do is we go for selective plantar fascia release. If you can see, this is the plantar fascia which is released over here, and if you can sorry, if you can appreciate, the first toe is going back significantly. So this is how we offload the thing surgically. Then there is another procedure called as scalous arthroplasty, where we remove the second phalanx base from the upper end for the ulcer, and it gets healed permanently. This is what the X-ray showing where the proximal excision has been taken out. Then there is we go for flexor tenotomy with the ulceration at the tip where the FHL is tightened. So we go with the percutaneous with a 18 blade number needle. Just insert the needle and go in this tangent manner, and we can release the tendon, and we can achieve the healing with it. This is a cloto deformity where the Gladstone talar tendon transfer has been done. This is what I mean to say. It's flexor digitorum longus to flexor to extensor extension with the Z plasty extensor has been done. This is what the correction post-operative came down. There is another entity where TA is tightened up, or the effect of the tricep cuff is more tightened up. So what we do is we go on with release of the gastrocnemius, so that the 4-foot ulcers, majorly the 4-foot ulcers, get released, and there is movement at the joint, so that the ulcer get healed up completely, and there is no recurrence of the ulcer later on. This is what the pre-operative, there is tremendous pressure over here. There is release of pressure over here. So we can appreciate the distance. There is pre-operative, it was 2.7, and post-operative, it is 1.3. There is another where if we have a second metatarsal head prominence over here with leading to ulcer formation, then we did a metatarsal head excision. Because of that, ulcer didn't recur and it healed completely. This is the X-ray where the metatarsal head is being excised. There is another way of first metatarsal head where we do Roberts-John EHL transfers. There is air force to accommodate the deformities and offloading offered. This is an individual offloading device or the footwears which has been customized for the individual patient. TCC, as we all know, and the advantages are compulsory or forced compliance is there. Shortened length stripe leads to pressure redistribution, reduces activity, so reduce plantar pressures, and this is a gold standard we all know in that way. This is what another patient where had second and fifth metatarsal head ulcers healed up in 55 days. TCC was applied with a bony window just to do daily dressings or alternate day dressings, and the healing gets achieved. As we all know that tendoachilles tightening is there once we go for a 4-foot amputation, then the fulcrum is been reduced. Because of the fulcrum going away, or mismanagement of the fulcrum happens, because of which biomechanical changes occurs, and there is a more pressure at the 4-foot or the midfoot where the transmetatarsal amputation has been done. The pressure goes on increasing there, so we need to release the tender achilles to manage these ulcers. So deformed foot with good footwear is preferable than amputated leg with a sophisticated processes. This is what I mean to say. Foot are there, deformed foot is there, a walkable foot. So it's more preferred. Faster the gait, higher the pressure. Longer the stripes, higher the pressure. So we need to alter the patient's what we say it as physical exercises schedules as per his deformities or pressures points and pressure studies and his neuropathical status. In patient with diabetic peripheral neuropathy, distance needs to be measured in minutes, not in kilometers. Prevention is the major goal. Protection of footwear for foot for further complications, and periodic offloading and continuity in the care is to be given. IWGDF guidelines states as the first choice is non-removable knee-high device (TCC) or non-removable walker. The second choice is removable walker, high heel or ankle devices if the first is not tolerated. The third choice is therapeutic footwears with fillers or foams. Surgical offloading techniques, which I've already explained, Achilles tendons release, metatarsal head excision or resection, osteotomy, digital tenotomies, and in infection and ischemia, treat as per the underlying issues, and use removable offloading device when it is safe. Do not allow your patient to leave the clinic wearing the same pair of shoe which has caused him an ulcer. Early detection protection of high pressure areas in the foot and corrective footwears or orthosis is the only strategy for preventing limb amputation in a diabetic patient. If a offloading of the affected limb is not done, then the patient will walk to its own death. Every diabetic foot is calling us, please save me, please save me, please save me. Thank you for your patience listening. Thanks a lot.